Hello, I'm Hogue Levins, and we're here at the Wharton School Video Studio. And today our guest is Dr. Ezekiel Emanuel, who's a vice provost of the University of Pennsylvania. And formerly, he was an advisor to the White House, and he is one of the architects of the Affordable Care Act. Dr. Emanuel, thanks for being with us.
It's great pleasure.
And today we're here to talk about your brand new book.
Correct.
And let me start at the beginning, the very cover. And the title of this is Reinventing American Healthcare. And the subtitle is How the Affordable Care Act Will Improve Our Terribly Complex, Blatantly Unjust, Outrageously Expensive, Grossly Inefficient, Error-Prone System. And my question is, were you at all concerned that subtitle is somewhat confrontational? It's somewhat absolute. Were you concerned at all that it might turn off some of the readers that you would otherwise be able to influence?
Well, I do think that the description there, the complexity, the inefficiency, the expensive, error-prone system are well accepted. We did, before the Affordable Care Act, have that kind of system that was terribly expensive and inefficient, had a lot of people uninsured. I do think that the Affordable Care Act is going to make a big dent in each one of those, and I make that argument in the book. Although I should say the book is not just an argument about the Affordable Care Act. It's sort of tries to educate people about the healthcare system, how various parties get paid, how insurance came about in the United States, all the efforts over hundred years of trying to reform it, how the Affordable Care Act got passed, what's in the Affordable Care Act. And then I do make predictions about the future. So it's not just about the ACA.
Okay. And in the book, you take the Congressional Budget Office to task. You talk about the tyranny of the CBO, and you say that although the Congressional Budget Office scores are objective and nonpartisan, they are frequently wrong. And you talk about the bias and how it can create real harm by placing roadblocks for important and worthy legislation. And you cite instances from 3 decades of wrong CBO estimates. So my question is, how did the CBO scoring impede the ACA? And if there had not been CBA scoring, how would the ACA be different?
So first of all, I also say that we need an umpire. I recognize that the role the CBO, the Congressional Budget Office, plays is absolutely essential. You have to have someone who's going to objectively assess a bill. But I also indicate, as you point out, that they have an institutional bias. They're always willing to, say, discount savings and assess higher costs than you might, because if they're wrong, things don't cost as much, or they save more than they anticipated, they think there's no harm done to the system. And part of what I wanted to point out is there is harm done to the system because good ideas that might have saved, they say, no, it's really not going to save, or it's only going to save a little, or it might even cost. They may be wrong on that and inhibit a lot of good ideas from coming forward. And I do cite the over 3 decades, from the 80s, the 90s, and the 2000s, cases of major healthcare legislation where they simply have underestimated the savings that could be achieved. The Part D, the Medicare drug benefit, is an excellent example. Their cost estimate was 40% too high. That makes a very big difference in setting policy, especially when every politician is constantly asking, how does it score, which means does it save money? And there are a lot of programs that we wanted to put in to the Affordable Care Act that didn't score, or didn't score as much as the CBO would say. And that means that, you know, when you're bargaining, you don't retain them as, for the bargain because, you know, it's not that expendable, or you can't get as much savings from them. And then there are, you know, I think I point out in the book, lots of things where there's no precedent, so they just guess. And I'm not, again, I didn't want to fault them. I did want to just indicate how it creates a certain kind of mindset. Everyone thinks they have this model which really does predict the future. Well, they have a model. It doesn't predict the future terribly well. And to constantly be trying to guess what they're going to score it, I think inhibits a lot more creative policy thinking than we might otherwise get.
Of the elements, for the potential elements for the ACA that didn't score, you know, which one was the most important one you thought should be in, and you regret it wasn't?
In general, and this is separate from scoring, in general, the thing I'm most frustrated by is that we didn't have more payment reform in the bill. because I do think that's a very important element to get us off the fee-for-service system, which encourages using more services and of particular types that are highly paid, to a system that doesn't encourage people just using services, but actually keeping patients healthy, keeping them out of the hospital. I think that's a very important switch. And again, this is a case where I think the CBO scoring was less favorable to those changes. The other thing I would say is that the CBO scoring tends to evaluate each individual change as opposed to putting them all together. And for, I think, many changes, a complete change that involves, IT, disease management, identifying high-risk people, putting in place interventions. Those haven't been regularly and rigorously tested, and so the CBO doesn't really have an idea about or doesn't think it can actually estimate with reliability savings. But a lot of places have seen those changes give you a sort of directional savings and a pretty good savings. And but it doesn't meet CBO standards for including in their model. And I think that kind of sort of experimentation doesn't get highly ranked. Nonetheless, I recognize the important role of the CBO. We can't work without it in Washington, but I do think we, and including the CBO, ought to recognize the biases and flaws and try to figure out ways to counteract them.
Okay. In your frequent TV appearances and your interviews in other media, at least the ones I've watched and the ones I've read, over the last couple of years, you've been perceived to be a staunch supporter of the Obama administration, obviously, and the ACA. Parts of this book, which are pretty critical, seem to have a totally different tone. Is this a dramatic departure for you to be so critical of internal White House management procedures now, as opposed to the stance you took publicly in the past?
Well, I think a lot of people have tried to pigeonhole me. In point of fact, when the exchange went bad, I had a pretty detailed critique in the New York Times, pretty public, about what I think they needed to do to solve the problem, including appoint a CEO. They haven't done that. And so I do think I've tried to be balanced in what has gone wrong and what has gone right. I've actually been pretty out in the open. I think it gets drowned out by the fact that I do think in general the ACA has been a big step in the right direction and is catalyzing positive change. But there are plenty of things, especially around the execution, that I think could have gone better. I am disappointed we still don't have menu labeling regulations. I have been disappointed about PCORI, the Patient-Centered Outcome Research Institute, not being aggressive enough. And I think I've been actually pretty upfront about that. But, not everyone notices all the nuances of an academic, and I think that's, I am generally quite positive. I think the bill did address many of the problems we had in the system, and I've often said it's not a perfect bill. In a democracy, you can't expect a perfect A-plus bill. You're going to get compromises, and that policymakers would prefer not to be there, but politics dictates that they are.
You mentioned the CEO issue, and in the part of the book that's a post-mortem inside the White House of what went wrong managerially, it's sort of inside baseball, but you can explain a little bit about why a different kind of CEO might have made a difference in the way that healthcare.gov went bad?
So I think you need to view the exchanges and the federal exchanges as a e-commerce site. We should not view it as a program in the government like the VA benefits. It is much more analogous to, say, Amazon or other e-commerce sites. And in that regard, it needs to be run like an e-commerce site, not like a government program issuing regulations. And that typically will require a CEO. It'll require a highly talented staff. It'll require constant tweaking of the exchanges, the rules, how you want to show people what their options are and educate them. And I've been pretty upfront about that. I was upfront about that beginning in 2010, that I thought this was necessary for proper execution. And I think if you look at the successful state exchanges like Connecticut, like California, they've had that structure where they've had someone typically with insurance company experience or running an exchange, being able to collect the right team, and basically every morning get up thinking about how are we going to make this better, how are we going to work with our suppliers, the insurance companies, how are we going to work with our customers to make sure they're having the right experience, or that we can adjust what we're doing to make it better for them. I think that's the proper way to run this thing. Again, on the idea that this is more an e-commerce site than this is a government program.
Back then, did anyone actually say to Nancy Ann DeParla, we should have a CEO of this
Yes.
type?
Yes.
And why did she elect to go?
Well, first of all, I don't think it was her decision. I think this was a decision inside the White House, and I can't tell you why they didn't go that route. I mean, I have, as I mentioned in the book, there was political considerations. They had the administration. We had been criticized about having too many czars of this and czars of that, and they were worried about additional criticism. But I think, as has become clear over time, getting the exchanges right was critical politically, and even if you took short-term criticism for appointing a CEO and creating this structure that would run it like a business, I think in the long term it was clearly not optimal to fail to do that.
In the book, on that point, you write, though, in a very positive way, there is no reason to despair or give up on healthcare reform itself. As many high technologies have shown, it is possible to bounce back from flawed website rollouts. But this is only possible if relentless focus on execution becomes a reality. So the question is today, has the White House changed, and is it relentlessly executing this correctly?
Well, clearly, when they appointed Jeff Zients to, I guess the correct word is rescue the exchange and websites, he was focused. The recent Steve Brill article does show that they really work 24/7. They got a really top-flight team, and I think that lesson should not be lost on them. That's really what you need when you launch. And let's remember, Twitter was not a flawless launch. Lots of other companies have had problems with launching their website that have come back to be very successful, and I certainly hope that the White House is paying attention to that.
Okay. Back to a subject you mentioned, payment reform, and in the book you have a section on that. And the whole issue of switching from a for-fee payment service to a more episodic one, I've gone to any number of seminars and conferences. This is a constant subject. But I haven't been to any where anyone actually presents a plan to achieve that. And there seems to be a great deal of confusion, inertia. No one knows what to do. How do you take a $4 billion a year urban healthcare network and completely unbuild its revenue systems at the same time you build something else that's not exactly defined?
Well, first of all, I do think I believe it's chapter 12 of my book, I do talk about health reform 2.0, and I do have a chapter or a section there about getting more alternative payment models to fee-for-service, and I do have a very plan, actually. So I do think that there is a plan. I would suggest that there are 3 or 4 steps that would be very important to this. And as you point out, you're not going to get, for example, the University of Pennsylvania overnight to be able to go from fee-for-service to alternative payment models. But the approach, therefore, is, well, let's give it a guide path, but all agree that at the end of some predefined time period, I say a decade, so 2022 is my time point. By 2022, 75 or 80%, pick a number, is off fee-for-service. And that gives everyone sufficient planning time and ability to shift. Then you pick particular areas where you think you can move off the fee-for-service system quickly and allow the hospitals and health systems to experiment. So as I say in the book, step 1 is we have had a recent Medicare experience called the ACE demonstration, the acute care episodes, which pays bundled payment for cardiac procedures and orthopedic procedures, stents, cardiac catheterizations, cabbages, coronary bypasses, pacemaker placement, hips and knees. You give the institutions and surgeons a bundle payment. That has shown to save some money and improve quality of care. That's a place to start, very defined. as I point out in the book, the bundle used by Medicare in the demonstration wasn't perfect, and we'd like to try an experiment to expand it, to include shared decision-making at the start, so every patient undergoing these procedures is given an information sheet or a video to see whether they want in or out, and then it includes rehabilitation after the procedure, as well as a guarantee for up to 6 months that anything that goes wrong, say with the hip replacement, is going to be covered free of charge. That you can phase in pretty quickly because we have evidence it works. Then you take another area like cancer, and I think cancer is a very good area because we have a lot of guidelines, we have a lot of agreement on how patients should be treated, and begin to identify very high volume, high cost cancers that can be bundled. And this, I think, provides you a pathway forward to move off the fee-for-service system into a system where people are not paid to do more, but to do higher quality care efficiently. And that, I think, is a plan that can take us to 2022 and shifting a lot of payments off the fee-for-service system.
And I think that's a great plan in theory. And I guess the question is, within the ACA, how do you actually get hospital systems to begin to do this?
First of all, the ACA, I do think one of the smart provisions we put in was the Secretary of Health and Human Services has the authority, without getting additional legislation, to nationalize, to take a experiment, a demonstration project that has shown to either save money and or improve quality, and nationalize it across Medicare. She doesn't need to go to the hospital. She can say, all right, in 2 years we're going to start paying this way, and give them 2 years to figure out how they're going to do it. Let's remember, we have a lot of really smart people running these health systems, including the University of Pennsylvania. You tell them what the rules are, they will adapt to those rules. I have no doubt about it. And they just want those rules. I mean, one of the things that's true as I go around the country is they feel like a lot of doctors and health systems feel like they're caught in two boats at the same time, which is they're paid fee-for-service and everyone is telling them, oh, you've got to improve the quality of your care, you've got to become more efficient, and yet they're not being paid to do those things. And they would, I think, in general, prefer to be paid to do that so they wouldn't lose money while trying to improve the quality of their system.
Okay. And in the payment section, you also get into graduate medical education, $10 billion for Medicare every year, and I can't remember whether your word was useless, but essentially it's not being tracked or assessed well how it's being used.
Right.
You indicate that the students coming out are simply not prepared for modern-day, digitally based, team-oriented care.
Right.
What's the answer to that? How do you change that? You say it must be changed. What are the changes, do you think, that should be
again,
made?
in the book, I think we make pretty clear during medical school, first, we ought to shorten medical school. Second, we ought to have some focus on training people in team-based care, training people in digital medicine, as you point out. How do you work with various wireless monitors at home or wireless compliance devices at home? That people need to be trained for that. We also need to train them in the outpatient setting. Right now, if you're in medical school and intern and resident, the vast majority of your time, 90+% of your time, is spent treating patients in a hospital. Whereas in the new system, much less time, much fewer patients are going to be in the hospital. Doctors are going to spend much less time treating patients in the hospital, and yet that's how we train them. So we need to emphasize you now have to provide half the training outside of a hospital. That's complicated. I recognize it. And again, this isn't a change that can happen overnight, but you have to give deadlines. Otherwise, no one's going to have an incentive to change their system. And I think those kind of changes, in addition, I think I mentioned in the book that we need to train doctors much more in management. Change management. How do you actually manage change? Negotiations, because they're constantly negotiating, whether with their colleagues or their patients or payers. We need to train them in strategic planning, how to use data, how to implement changes. So I think there's a lot that needs to be done to change the medical education we've had. I mean, one of the ironies is medical education really took the structure it has today 100 years ago with the Flexner Report. Medical system has changed a lot. The kinds of treatments we're giving to patients have changed a lot. You would think medical education should change more than it has.
Okay. One of the in your book, you go through various trends as you look forward and bravely make predictions about what's going to happen, and you say this is a brave task.
I recognize the stupidity of making predictions, mostly because Phil Tetlock is a professor here at the Wharton School and at the University of Pennsylvania, and he's written a whole book about how dangerous it is for experts to make predictions. So I recognize it's difficult, but I also recognize it's essential. All of us are making predictions about the future, whether you're running a hospital, whether you're a doctor or an investor. You're making predictions about how the future is going to evolve. And I thought, well, I've got a lot of experience, knowledge. I'll make some predictions. And again, I've learned from Phil Tetlock that you got to be very specific. What exactly quantitatively is a prediction, if there's a quantitative prediction, and give a specific date. So I try to be as rigorous as possible, and I know that I might be held up to laughter and insult if my predictions turn out to be wrong.
One of those predictions is that in the next 6 years, at least 1,000 hospitals across the country will close. And within that, you suggest that the community, either that part of the community that works at those hospitals or the patients who use those hospitals, that they should not fight this. Can you explain that more? Why would we want to see 1,000 hospitals close and just let it happen?
First of all, the hospital occupancy rate in the United States is now under 70%. That means there are lots of beds that are not being occupied. And there are a number of hospitals under 50%, and they are not necessarily shouldn't necessarily be there. Take Vermont. For a population of 400,000 people, they have 11 hospitals. That's just unnecessary. Second, a lot of these hospitals, as I mentioned, one of the reasons we're going to see hospitals close is because a lot of care that hitherto had been delivered in hospitals can be more effectively and at less cost delivered at home or in other settings. There's no reason to go into a hospital, for example, for a colonoscopy. You can do it in an outpatient setting at a cheaper rate and with the same kind of quality. Many patients who we used to admit to the hospital, for example, for exacerbations of emphysema or congestive heart failure, can be treated just as well at home. So we'll see that shift. Well, if you treat people at home, the nurses, as I think I make clear in the book, who were once working the halls are now going to be visiting patients at home. They're not going to be unemployed. If the main worry about closing a hospital is employment, we'll lose important high-paying jobs, we're going to shift those jobs to other services in the healthcare industry. Well, I'm a cost control hawk, you might say, when it comes to healthcare. I am also a realist. We are not taking a system that now is spending $2.9 trillion on healthcare and going to reduce that to $2.6 trillion. The only question is, how fast or slow does it go up from $2.9 trillion to $3.2, $3.3 trillion? And to the extent that it's on the upward slope, that means more people are going to be employed in the healthcare system, more services are going to be delivered, and therefore I think when we close hospitals, we shouldn't look as if all of that's going away. It's going to be redeployed in other areas. People who were coming into this hospital aren't suddenly not going to need healthcare services. They're going to need them in a different way, in different facilities, or maybe at home. And that's going to be, I think, if you're worried about the employment part, going to employ plenty of people, and I think, again, is going to be better for patients. And we should remember the main goal of a healthcare system is not employment. The main goal of a healthcare system is keeping the population healthy.
Okay, and one of the last questions, we're talking about updating the law. And in the book, you're talking about the ACA is an enormous thing. It'll make significant changes, even as it will need further modifications and revisions. And just the other day, we had Andrew Dreyfus from Massachusetts come, and he and others talked about how in Massachusetts, since the law was passed in 2006, it's been significantly amended 6 different times, and they anticipate an ongoing, endless amendments because of corrections, because of unintended consequences, etc. The ACA is one, it never made it through conference. Now it's like a non-dynamic law. What do you see happening as this non-changeable law pushes forward and can't be corrected? Is that sufficient to cripple the ACA, or where is that going to go? It seems in the poison atmosphere of Washington, it's unlikely that it will be amended. Is that fair?
So I think what Andrew Dreyfus says is right. Healthcare, I think the opening line of my disclaimer is healthcare is dynamic, and we similarly need policies and laws and regulations relative to healthcare to be dynamic and to respond as the system evolves, as flaws are found. And ironically, if you talk to people in Washington who, when they're not engaged in the partisan battle, there's a lot of agreement about the kinds of changes they want to be put into place, but we're locked into this, what seems to be an endless battle over the soul of the ACA. I actually believe that's unfortunate. I think almost everyone, no matter whether you're Republican or Democrat, believes it's unfortunate. And I think that we're probably going to fight 2 more elections on the ACA, the 2014 election and maybe the 2016 presidential election. And then hopefully, my hope is that we'll be able to get, all right, it's the law of the land. Let's deal with the problems and let's see if we can improve things. I will say my best hope on that regard is before I went on TV last night with Bill O'Reilly, he said to me, look, I don't want to talk about the ACA. It is the law of the land. It's coming into being. I want to talk about responses to it and for example, how doctors are responding or not responding and don't want to participate in the ACA. And I took that as, wow, that's revealing. And, I wish he would say it on the air because that, I think, would change the discussion and allow us to move forward. But I can tell you I've talked to a number of staffers of Republican senators and congressmen, and they recognize and actually have a lot of agreement with the things I want to propose. I think, when I talk to conservative health policy experts, there's a lot of overlap, 60, 70% overlap between my views and their views. And I think we could actually make a lot of progress if we put the ideology behind us and try to improve the healthcare system in this country. And, I was involved in enacting the ACA and helping to design various provisions. I recognize it's flawed. It's not a perfect bill. As I said before, it's not an A bill. You're not going to get perfection in a democracy. And it needs to be healthcare system needs to be constantly tweaked. The idea that we do it once and for all, that is just false.
And looking down the same road, in the book you talk about how the ACA has been a great achievement for President Obama. At the same time, it has wounded him politically really badly. And you also say that you think, down the road, that history will actually look back at him and smile. Tell us how and why. Not many people are students of American history, but let's take a pause and a little diversion to answer your question. Harry Truman, when he was actually president, was not very popular. Some people don't fully remember, but the 1948 in that year, he was more or less written off. Everyone was sure he was not going to be reelected. Even the Chicago Tribune on election day published, Dewey defeats Truman. So here's a guy who is not very popular, and a lot of the things he did, integrate the Army, drop the bombs on Hiroshima, the Marshall Plan, NATO, the Cold War, were at the time, he wasn't popular for integrating the Army. The Marshall Plan barely passed the Senate. He had to call it the Marshall Plan instead of the Truman Plan to get it to pass. Not very popular president. Now we lionize Harry Truman, and we think he's like the greatest. He's a near great president. Behind Washington, Lincoln, and Franklin Roosevelt, he stands with people like Teddy Roosevelt and others as a near great president. Well, I think that the Affordable Care Act is going to play the same way. Once it plays out, once it begins to transform the system, if in fact even half my predictions are true, it gets healthcare inflation down to GDP. It transforms the delivery, so we're really taking care of the chronically ill and the mentally ill. You will see people say, wow, this really did make a very positive move in the system. It was a very important change. It's going to take a decade to see those effects, I believe, again, because we're dealing with such a big part of the economy, such a complex part of the economy. I would also say, I think I say this very clearly in the book, the wounds that politically have been suffered because of the ACA are a result of bad communications about the ACA, what's in it, what it means for the average person, and the bad implementation of the exchanges, neither of which were inherent or necessary. Both were, as I say in the book,
somewhat self-inflicted. We didn't, and the Obama administration didn't do a particularly stand-up job either of communicating around it or executing. And I think there's nothing inherent or necessary in the ACA being viewed as negatively as it is today. It could have been different.
A perfect ending. Dr. Emanuel, thanks for being with us, and good luck with your book.
Thank you very much.